ASCO 2016, what will we remember going back when we go back home starting tomorrow after the end of ASCO? In sarcoma, there will be focused on three different parts of our discussion today. First is the role of high-dose chemotherapy for a cancer called Ewing sarcoma, which is seen predominantly in kids. And after the presentation today, the oncology community was still left in doubt whether high-dose chemotherapy, which is a rather toxic approach, with or without radiation to the lung, should be considered a standard of care. And there is no consensus on that opinion by the discussant who reviewed the data today from several large European trials. The other two areas, first in the area of targeting what we call receptor tyrosine kinases. There is a drug already approved in this in sarcoma called pazopanib or Votrient. And in one study today, the question was asked whether adding chemotherapy to pazopanib would be better than pazopanib alone. Though the study was positive, there were certain issues with the study in terms of its overall outcome, and the consensus of opinion after reviewing the data today was that the addition of gemcitabine to pazopanib added increased toxicity without an added benefit to the patient, and at this point, pazopanib as a single agent would still be considered the standard of care and not pazopanib plus gemcitabine. There are other drugs presented that also block receptor tyrosine kinases. One of them is called regorafenib. This is a drug that's active in GIST. We've seen this data before for GIST sarcomas. Today's data looked at the other sarcoma subtypes to see whether it had activity in these tumor types as well. The data does show that regorafenib, when compared to placebo, is an active agent in several sarcoma subtypes, including synovial cell sarcoma and leiomyosarcoma. The question, though, is it better than the current standard drug, pazopanib, which has been shown to be superior already in a placebo-controlled randomized phase 3 trial? Today was simply randomized phase 2 data. At this point, the consensus is, though this drug does look active in these sarcoma subtypes, at this point there's no strong pressing rationale to abandon pazopanib in favor of the newer drug regorafenib. And finally, there was extensive data presented on immuno-oncology and sarcoma, a very hot subject at ASCO in view of its activity in melanoma and lung cancer and bladder cancer. Overall, the data was a little bit disappointing. The response rates were low. The problem about sarcoma is in fact not just one cancer, but 60 different cancers. And how do you design a clinical trial that addresses all those patients and all those subtypes with studies that in fact number no more than 85 to 90 patients? Well, it's quite impossible, and you hope in doing a study like this to see signals of activity in certain sarcoma subtypes. And in fact, the study from Sark, presented by Dr. Talby from MD Anderson, did suggest there were at least 2 sarcoma subtypes where there's a glimmer of hope in terms of response to immunotherapy with a drug that targets an immune checkpoint called PD-1, the drug being called pembrolizumab from Merck. And the subtypes included a rare tumor called malignant fibrocystic MFH, now been reclassified as undifferentiated pleomorphic sarcoma, quite a mouthful, and also a subtype called dedifferentiated liposarcoma. Again, very small numbers, but a hint of activity in the sarcoma subtypes, and now that represents opportunities to expand those subtypes in bigger clinical trials. We also saw data that was absolutely negative in a subtype called leiomyosarcoma, a study presented by Dr. Suzanne George from Dana-Farber, where there was no activity in that sarcoma subtype, indicating that we need to do a lot more science to understand why do some sarcomas respond and why do some sarcomas not respond. And that led to the third presentation today, looking at biomarkers, including PD-L1 and other biomarkers that may give us future directions in selecting patients for this type of therapy. So at ASCO 2016, we're left with the hope that immunotherapy will find a niche. It wasn't completely negative, though perhaps a little more disappointing than we'd hoped for, but still hope breeds eternal. And as oncologists, we can always hope for a better future for our patients with sarcoma.